Have you ever felt an intense burning pain or an uncontrollable tightening of your muscles when trying to use a tampon, undergo a pelvic exam, or engage in sexual intimacy? For too long, women have been told this pain is just in their heads. But the truth is, this is a very real, highly treatable medical condition. Welcome to our video, Understanding and Treating Genito-Pelvic Pain or Penetration Disorder. Today, we are breaking down the science, the symptoms, and the highly effective treatments that can help you reclaim your body and your life. In the past, the medical community split female sexual pain into two separate diagnoses: dyspareunia, which meant painful sex, and vaginismus, which referred to the involuntary spasm of vaginal muscles. However, researchers realized these two conditions heavily overlapped, with many women experiencing both pain and muscle spasms simultaneously. Because of this overlap, modern medical guidelines have combined them into a single, comprehensive diagnosis called genito-pelvic pain, or GPPPD. This condition is classified as a specific sexual dysfunction, highlighting its profound impact on a woman's sexual response, physical comfort, and relationship dynamics. To be officially diagnosed with GPPPD, a patient must experience one or more core symptoms for at least 6 months. These include persistent difficulty achieving vaginal penetration, marked pelvic or vulvovaginal pain during penetration attempts, an intense fear or anxiety regarding the anticipated pain, and the pronounced involuntary tensing of the pelvic floor muscles. GPPPD can be categorized based on when it started. Primary GPPPD means the symptoms have been present since the very first time vaginal penetration was attempted, whether that was with a tampon, a medical instrument, or during first sexual intimacy. Secondary GPPPD, on the other hand, develops in individuals who previously had no issues with penetration. After a period of comfortable, pain-free experiences, symptoms suddenly or gradually develop, often triggered by a physical trauma, a new medical condition, psychological stress, or shifting relationship dynamics. If you are dealing with this, please know that you are not alone. Studies show that up to nearly 26% of female university students report experiencing at least one core symptom of GPPPD over a 12-month period. It is incredibly common, yet rarely talked about openly. This condition often creates a vicious cycle. Chronic pelvic pain and the inability to engage in intimacy can trigger deep feelings of inadequacy, shame, and anxiety. In turn, this pre-existing anxiety actually lowers your body's threshold for pain and increases subconscious muscle guarding, making the physical symptoms even worse. At the physical level, GPPPD is driven by an overactive pelvic floor. The levator ani complex, the muscles supporting your pelvis, remains in a constant state of high tension or hypertonicity. This persistent tension restricts local blood flow, drastically decreasing natural vaginal lubrication. Because of this lack of lubrication and tight muscle barrier, any attempt at penetration creates severe friction, tissue irritation, and even microabrasions. These tiny physical injuries send intense pain signals to the brain, which reinforces the brain's association that penetration equals a physical threat. To treat this condition effectively, healthcare providers must determine if you are experiencing superficial entry pain or deep pelvic pain. Entry pain happens immediately upon touch and can be caused by localized conditions like vulvodynia, provoked vestibulodynia, unhealed childbirth scars, or localized infections. Deep dyspareunia, however, occurs during deep penetration or thrusting. This deep-seated pain is often linked to internal medical conditions such as endometriosis, pelvic inflammatory disease, uterine fibroids, ovarian cysts, or internal scar tissue from previous pelvic surgeries. Hormones also play a massive role in pelvic pain. Drops in estrogen during menopause, postpartum recovery, or breastfeeding can thin the vaginal lining, causing it to become fragile and dry. Even medications like certain oral contraceptives, acne treatments, and antidepressants can alter your hormones and decrease natural lubrication. A proper diagnosis starts with a compassionate medical exam. Because anxiety is high, your doctor may use strategies like explaining every step, letting you use a handheld mirror to see what they are doing, or guiding your hand to maintain control during the exam. During the exam, a doctor might use a simple, moist cotton swab, known as the Q-tip test, to gently touch different areas around the vaginal opening. This helps them map exactly where the pain is located and determines if the pain is provoked by pressure, which is a hallmark of vestibulodynia. Once diagnosed, the most highly recommended physical treatment is pelvic floor physical therapy. But here is a crucial warning. Traditional Kegel exercises are strictly contraindicated. Kegels focus on contracting and tightening muscles, which will actually worsen the spasms and pain of GPPPD. Instead, pelvic floor physical therapy focuses on downtraining and lengthening the pelvic muscles. One of the foundational techniques is diaphragmatic breathing. By taking deep belly breaths, your diaphragm moves down, naturally encouraging your tight pelvic floor to drop, open, and relax. Physical therapists will also teach you reverse Kegels. Rather than squeezing in, you focus on a gentle, conscious outward relaxation of the pelvic floor. Imagine the muscles opening up and blooming like a flower on a deep inhale. Certain yoga stretches are incredibly effective for opening the pelvic floor. The happy baby stretch, where you lie on your back and draw your knees toward your armpits, physically stretches the pelvic muscles. Child's pose is another gentle, deeply relaxing stretch that releases tension in the pelvic diaphragm. Inner thigh muscles connect directly to your pelvic region, so stretches like the butterfly stretch and deep squats are also excellent. In a deep squat, you can even support your heels with a rolled towel or yoga blocks, allowing your pelvic floor to fully stretch and release tension. Another powerful tool is biofeedback. Using surface sensors, biofeedback displays your real-time muscle activity on a screen. This allows you to visually see your muscle tension, helping your brain learn exactly what it feels like to consciously command those muscles to relax and let go. Once your muscles learn to relax, the next step is vaginal dilator therapy. Vaginal dilators are smooth, medical-grade, cylinder-shaped tools that come in graduated sizes. They are designed to gently retrain your nervous system, proving to your brain that penetration can be safe and completely pain-free. A dilator session always begins with relaxation. After 5 to 10 minutes of deep breathing and stretches, you apply a generous amount of water-based lubricant to both the smallest dilator and the vaginal opening. Water-based lube is crucial, as silicone-based lubes will permanently damage silicone dilators. You then angle the dilator slightly downward toward your tailbone and insert it very slowly while focusing on deep, lengthening breaths. If you feel any sharp pain, you must stop immediately. Forcing it will only reinforce the brain's association between penetration and trauma. Once comfortably inserted, you can use the clock pattern technique, gently sweeping the dilator in a circle to identify tender spots, avoiding the 12 o'clock position to protect the urethra. When you find a tight spot, apply gentle, sustained pressure while breathing deeply to release the trigger point. You only progress to the next dilator size after the current size can be inserted and moved in and out with absolutely zero pain or muscle guarding across multiple sessions. Remember, short 5 to 10 minute sessions a few times a week are much more effective than long, infrequent ones. Because GPPPD is deeply intertwined with anxiety, psychotherapy, specifically cognitive behavioral therapy, is highly recommended. CBT helps you identify and reframe negative thoughts, overcoming the fear of pain, addressing body image concerns, and removing the shame often associated with sexual dysfunction. Advanced trauma therapies like EMDR are also incredibly effective if your pain is rooted in a history of sexual abuse, painful medical exams, or traumatic childbirth. These trauma-informed approaches help the nervous system unlearn its protective clenching response at a profound neurological level. It is also highly beneficial to involve your partner in therapy. Partner-guided exercises focus on exploring non-penetrative pleasure, separating intimacy from the pressure of intercourse. This allows couples to rebuild comfort, trust, and desire without the looming anxiety of pain. For severe refractory cases of vaginismus where physical therapy hasn't fully worked, localized botulinum toxin, or Botox, injections are a highly effective medical intervention. Administered under sedation, Botox temporarily paralyzes the hypertonic pelvic muscles, forcing them to relax. This temporary muscle block breaks the cycle of anticipatory guarding, allowing the patient to finally engage in physical therapy and dilator training without pain. With a combined approach of physical therapy and psychological support, clinical success rates for overcoming this condition soar to 86%. Healing from genito-pelvic pain or penetration disorder takes time, patience, and self-compassion. The road isn't always perfectly linear, but a pain-free, fulfilling life is entirely possible. Don't suffer in silence. Reach out to a specialized pelvic floor physical therapist or a sexual health provider today to begin your journey to recovery.